Ladies and gentlemen, it gives me great pleasure to introduce to you the faculty orator for the year 2021, Dr. Sumudu Nimali Seneviratne, MBBS, DCH, MD, PhD. Sumudu is a senior lecturer in the Department of Pediatrics of the Faculty of Medicine of the University of Colombo. And she is also an honorary consultant pediatric endocrinologist at the Lady Ridgeway Hospital for Children in Colombo. She had a primary education at Musaeus College in Colombo and secondary education at Visakha Vidyalaya. At Visakha, she obtained distinctions in all subjects and was placed first in the island at the GCE O-level examination in the year 1993. She was also fifth in the island from the biology stream at the GCE advanced level examination in 1996. At school, she was a senior prefect, president of the Buddhist Society, secretary of the Science Society, vice president of the English Literary Association, as well as a member of the Senior School Western Band and School Choir. She was awarded the Susan George Polymood Gold Medal for the Best Student at Visakha in 1996. She entered the Faculty of Medicine, University of Colombo in 1998 and obtained her MBBS degree with first-class honors in the year 2004. She had gold medals and distinctions in clinical medicine, forensic medicine, and pediatrics. She then proceeded to take up clinical training in pediatrics, obtaining her diploma in child health and Doctor of Medicine in Pediatrics in the year 2011. She joined the Faculty of Medicine as a probationary lecturer in pediatrics in 2010. She proceeded to overseas training as a clinical research fellow in pediatric endocrinology to Auckland, New Zealand in 2012. She completed her clinical training at the Starship Children's Hospital in Auckland and obtained a PhD from the Liggins Institute, University of Auckland in New Zealand in 2015. The PhD was awarded based on her thesis, The Impact of Antenatal Exercise on Overweight and Obese Women on Maternal and Offspring Outcomes. She was promoted senior lecturer in pediatrics in 2015. She has authored 58 research publications, including many first author publications in high-impact peer-reviewed journals, such as Hormone Research in Pediatrics, Journal of Clinical Endocrinology and Metabolism, American Journal of Obstetrics and Gynecology, and BMC Public Health. She has presented 114 research abstracts, including 44 at international conferences, and received 3 research awards, including the President's Research Award in 2016. Her clinical and research interests include differences in sex development, congenital adrenal hyperplasia, fetal programming, childhood obesity, and endocrine complications in pediatric cancer survivors. She successfully coordinated a 3-year multi-stakeholder national level project to motivate healthy eating habits among primary school children in Sri Lanka. She is currently working with the Asia Foundation to create a center for children and adolescents with complex hormonal disorders, which I know will come into fruition in the new building once it's inaugurated next year. On a personal note, I came to know Sumudu when I was the chair of the Research and Higher Degrees Committee around the year 2016, 2017, more closely, beyond the fact that she was a student in the faculty. And at that time, we wanted to promote research communication amongst the students. And following a discussion in the Research and Higher Degrees Committee, we asked who would take the leadership. And Sumudu put her hand up and took on the challenge and introduced the bus stop talks that she was acquainted to in Australia to our faculty, and has been running a successful series of bus talks, improving research communication among our postgraduate students. And now we have extended it to the undergraduate students as well from this year. It gives me great pleasure, ladies and gentlemen, to invite Sumudu to come over and receive the Faculty Oration Medal and to deliver her oration. Sumudu.
A very good evening to you, ladies and gentlemen, and thank you, sir, for those kind words. I am truly honored and humbled to have the opportunity to deliver the Faculty Oration 2021. So, ladies and gentlemen, 10 years back, I did not have much knowledge about fetal programming. But today I stand here quite convinced that it is playing a major role in the diabetic pandemic that we are facing in Sri Lanka today. So let me start by wishing you all Ayubowan, Kiora, from two beautiful nations of the world. And they both mean, may you live long. But unfortunately, diabetes and obesity is causing mortality and morbidity, and especially premature mortality among all nations today. So ladies and gentlemen, I invite you to take a trip around the globe and let's look at this problem a little bit more in detail. So in the words of a great philosopher, when there is a problem, we first need to look at the reasons for the problem before we can find the solution and the way towards it. And so when we consider the diabetes and obesity pandemic, we know it's a global issue. And let's look at this problem a little bit more in detail. Now, this graph shows the global prevalence of diabetes by country income group between 1980 and 2014. And if you look at 1980, at the start of the graph, you can see that the high income countries shown in yellow have the highest incidence of diabetes in the world. But 10 years down the line, we can see that the lower middle income countries, such as ours, shown in purple, as well as the high middle income countries shown in green, now start to show a higher rate of diabetes. And the landmark studies done by Professor Kadulanda et al. In 2008 showed that we in Sri Lanka had a diabetes prevalence rate exceeding 10% in 2006. So ladies and gentlemen, we were not doing so well with regard to diabetes. And so we know that diabetes is strongly linked to obesity. And if we go back and look at the trends in obesity, you can see the dramatic increase in obesity which has occurred over the last 4 decades. So ladies and gentlemen, the pink line shows obesity in adult women, the blue line in adult men, and the discontinuous lines show obesity among boys and girls. So in 1975, a few years before I was born, you can see that the rates were less than 100 million. But today, it is greatly higher. And childhood obesity, in specifically, we can see that the percentage rise has been almost tenfold or greater. And ladies and gentlemen, we are talking about the double pandemic during this session, and we still do not know what devastation that COVID-19 has done to the obesity diabetes pandemic, but it is likely that it has worsened it much more. Now, this graph shows the prevalence of obesity among children aged 5 to 19 years across the world. And the graph on the right shows the number of obese girls in millions. And on the left, we see the obese boys in millions. And ladies and gentlemen, you can see towards the beginning of the graph in the 1980s, a major component of these obese children were from high-income countries. But after 2010 and more recently, we see a large proportion of children from the Asian countries shown in the red and orange colors, and also in South Asia where we live. So let's look a little bit at obesity. What is it and why does it occur? Put in very simply, obesity refers to the accumulation of fat in the body to an extent that it is harmful to our health. It occurs when our food intake exceeds our energy expenditure over a long period. And how does obesity then lead to diabetes? So if you have a normal amount of body fat, we need a certain percentage in our body. If you have a normal amount of body fat, then those adipocytes will not cause harm to us, and they will be secreting adipocytokines, mostly of the anti-inflammatory nature, which are not toxic. But as our fat cells accumulate more and more fat, these fat cells start secreting toxic pro-inflammatory cytokines, adipocytokines, such as TNF-alpha, IL-6, which lead to a state of low-grade inflammation and cause insulin resistance. So these substances do not allow the insulin in the body to work and lead to type 2 diabetes. But ladies and gentlemen, we still do not know why obesity is increasing so rapidly in the world, and also why it is so difficult to cure. So even in developed countries such as US and Europe, obesity rates, though they do not continue to rise, still have not shown any decline. And we do not have easy solution to this problem. Now, ladies and gentlemen, so let's take a moment and try to figure out the reasons for these issues. We all tend to think that unhealthy lifestyle is the main and only reason why obesity is increasing rapidly. And we all know that urbanization, technological development, change in transportation, and mass media have greatly changed our occupational, household, leisure time activity levels, as well as our dietary patterns. However, ladies and gentlemen, I invite you to ponder whether this is purely the only reason for the rapid rise in obesity and diabetes we are seeing over the last very short time of relatively few decades. So this is in the 2020s, as was discussed, we are seeing a lot of new technology being used, which is obviously causing a reduction in our physical activity. We see a lot of food advertising and fast foods. But ladies and gentlemen, in 1980s too, we did have some of these things. Television was still available. We did have some supermarkets starting in the 1980s. And we did still, at least in the urban sector, have overcrowding and urbanization. So technological advancement had already arrived. But the obesity rates have been very, very dramatically increasing. And further, none of this explains why obesity is so hard to cure. If it is purely due to unhealthy life choices, why cannot we reverse it? So it appeared to me that there was a missing link that we are not seeing yet. So during this time in 2012, I got the opportunity to read for a PhD at the Liggins Institute, University of Auckland, New Zealand, when I went for my clinical training in pediatric endocrinology. It was a serendipitous thing. They just had this opening. So I was very lucky to get involved in this program. And the Liggins Institute is it's a specific research institution in the University of Auckland where they focus purely on improving lifelong health, looking at the very early stages of life. And this is where I got a much deeper insight and knowledge about the concept of fetal programming, which I aim to explain a bit more in detail now. So what is fetal programming? So in the late 1980s, David Barker and colleagues, as well as few other scientists from around the world, first reported that now if you look at the graph, it shows the birth weight on the x-axis and the frequency of NCD-related diseases on the y-axis and infant mortality. And what he found was that babies born, people who have a born with a birth weight, a low birth weight, below 5 pounds, had not only a higher rate of mortality as children, but they were also having early death due to heart disease before 60 years of age. So premature mortality, as well as much higher risk of hypertension, type 2 diabetes, coronary artery disease, and stroke. And so none of the things that we discussed earlier explained this phenomenon. And this elegant study done in 2012, spanning around more than 600,000 people from 26 countries around the world, shows the relationship between birth weight, now in kilograms and grams on the x-axis, and a measure of risk of overweight on the y-axis. And ladies and gentlemen, you can see that there is a J-shaped relationship. So while David Barker recognized the effects of low birth weight, we were now seeing trouble 15 years, 20 years down the line on both ends of the birth weight spectrum. And indeed, the higher birth weight babies seem to be having a higher risk. And all this we thought was due to fetal programming. So ladies and gentlemen, the answer to the questions why obesity is increasing so rapidly and why obesity is so difficult to cure, part of that answer may lie and does lie indeed within fetal programming effects. So let's look a little bit in detail about fetal programming and why does it occur. Now we were speaking about children at both ends of the birth weight spectrum. So if we look at the smaller babies first, we know they are subject to fetal undernutrition, and that is due to either maternal undernutrition or due to insufficient energy transfer from the mother to the baby via placental insufficiency. And on the other hand, if you look at the larger babies, they are subject to fetal overnutrition due to either pre-pregnancy maternal obesity, hyperglycemia in pregnancy, or excessive gestational weight gain during pregnancy. And so, ladies and gentlemen, perhaps we could see or find a solution in this concept. So during my time in Auckland, my work was based more on the babies at the upper end of the birth weight spectrum. So this elegantly illustrates how maternal overnutrition leads to an increased risk of obesity in later life. If we look at pre-pregnancy obesity, this, together with excessive, with or without excessive gestational weight gain, increases one's chance of getting gestational diabetes. In addition, each of these factors independently alter fetal growth and metabolism. We know that these babies have a larger birth weight, more adiposity, higher levels of insulin and leptin when they are born. And this in turn is associated with altered body composition, increased adiposity in childhood, leading to childhood obesity, which then follows on to adult obesity and type 2 diabetes. And further, the mothers also tend to have, those with excessive weight gain, tend to have postpartum weight retention, and which leads to later life type 2 diabetes in them as well. And then both these, the mothers who are obese after their first baby, as well as their babies who, female children who grow up to be obese adults, they then tend to propagate this obesity cycle. So we ourselves explored this concept and we found that offspring or babies born to mothers who had higher BMI pregnancy had an increased body mass index and increased body fat at 1 year and 7 years of age. And also babies whose mothers had had an excessive gestational weight gain had excessive abdominal adiposity and an abnormal lipid profile in early and mid-childhood. So effectively, we were seeing an intergenerational obesity cycle. So maternal obesity was leading to neonatal obesity, which was then perpetuating into childhood and adult obesity, setting in an intergenerational vicious cycle. And the reasons for these are yet being unraveled, but we do know that the abnormal metabolic milieu leads to fetal overnutrition, increased fetal insulin and leptin. And these have been shown mainly in animal studies that they lead to hypothalamic dysregulation with dysregulation of appetite and energy balance. So these children have increased appetite and less tendency to energy expenditure. And we also know that epigenetic changes and changes in the gut microbiota are also part of this mechanistic pathway. So ladies and gentlemen, we wondered whether we could find a way towards a solution in this manner. So the million-dollar question was, could we prevent or reverse fetal programming? Now, we found some elegant studies done in 2006 and 2009 in women, very overweight women who had undergone bariatric surgery and had babies after that, as well as before bariatric surgery. So this team looked at the babies born to these women before and after they underwent bariatric surgery. So conceived before as well as conceived after, sibling pairs with the same parents, same genetics, same home environment. And what they found was babies who had been born after significant weight loss by bariatric surgery had almost normal levels of obesity risk. whereas their older siblings who had been born when these mothers were much more obese had threefold higher risk of obesity, especially severe obesity. So this kind of was the first proof that actually the in vitro environment was causing this and also was modifiable by. But we do know that bariatric surgery is not a measure which is available to the vast majority of obese and overweight women world over. And so my work focused on whether we could lifestyle interventions during pregnancy could also have a somewhat similar protective impact, and whether this could protect the babies in their future lives. So I went on to study the impact of antenatal exercise in this regard, looking at a cohort of overweight and obese women and the effects of this on both their as well as their offspring health. And the underlying basis behind this work was actually to see whether antenatal exercise could help prevent adverse fetal programming. So we looked at the literature and found that there is indeed a research gap, and we were not sure at this point of time, there was not much literature on this. And then we proceeded to conduct a randomized controlled clinical trial. We named it the IMPROVE trial to see whether we could improve maternal and progeny risk of obesity via exercise. And started off by publishing the study protocol. And we recruited 75 overweight obese women from the community, volunteers without medical contraindications, and randomized them based on their ethnicity and parity to either a control group or an exercise group. So the control group had no exercise intervention, but they were free to continue any activities they were usually performing. The exercise group were prescribed a 16-week home stationary cycling program. They were provided with these bicycles to use at home, and they were given heart rate monitors with downloadable data so that we could monitor their compliance with the prescribed exercise as well as the intensity that they were doing. And this home-based program was advocated to make it easier to comply with the exercise. And so this is how the study started. So at baseline, before 20 weeks of gestation, we looked at the physical activity, diet, and social demographic data. And we also assessed maternal weight and fitness by a submaximum aerobic test, looked at their quality of life and a multitude of metabolic markers. Then the intervention period was from the 20th week of gestation to the 36th week of gestation. During these times, this period, both groups underwent 4-weekly, 3-dimensional fetal scans to see the body composition and growth of the babies. Both groups maintained exercise diaries, and we also assessed their physical activity, habitual physical activity and diet by questionnaires, self-reported in the mid-intervention period. And then at 36 weeks, we looked at maternal weight and fitness again, as well as the metabolic markers in both groups. At delivery, we collected cord blood to look at the baby's metabolic profile. And 2 weeks after delivery, we called them and looked at their pregnancy and delivery data, and also conducted DEXA scans on both the babies and the mothers to look at their body composition. And these were the baseline data. So we had women around 31 years of age on average, with a BMI of around 30 at baseline, of both New Zealand Caucasian and South Pacific ethnicity. And they had similar educational level, income, employment, diet, physical activity. Their baseline fitness levels, quality of life, and metabolic markers were similar. And when we looked at their maternal outcomes at the end of the intervention period, we found that the ladies in the exercise group had improved their fitness level. So you can see in red that they could go on the cycle for a longer time period, indicating a higher level of fitness. And you can see in the control group that actually their fitness level has decreased as their pregnancy advanced. So this was a very positive finding. However, unfortunately, we did not find any benefit in maternal metabolic markers, nor in the gestational weight gain, nor in quality of life pregnancy outcomes or delivery outcomes. And more specifically, the main primary outcome was birth weight, but we did not find a difference in offspring birth weight, fetal growth, metabolic markers, or the postnatal fat and lean body mass of these babies. So we had a negative trial. And the most likely reason for this, we felt, was the suboptimal exercise levels. You can see as pregnancy progressed, the compliance with exercise went down. And ladies and gentlemen, these were very, very willing participants. They wanted to do this, but yet it was difficult. So we thought that it is highly unlikely that this would be a practically applicable intervention for the community. It's highly unlikely to work in a less stringent population. So we also looked at another cohort of children whose mothers had exercised, looked at their longer term outcomes. And again, what we found was we couldn't find any positive effect of antenatal exercise on offspring risk of obesity. So ladies and gentlemen, we couldn't find a solution. So by this time I had to return back to Sri Lanka. And this is a picture of the obesity clinic at the professorial pediatric unit at Lady Ridgeway Hospital, which was started in 2004 by Professor Shamya De Silva and developed by Professor Pujita Wickramasinghe, which I now conduct. And I gained a lot of my knowledge about children with obesity from these children. So in 2015-16, we looked at what was happening in Sri Lankan children. And you can see that we found very high levels of metabolic complications in these young children. And you can see that 10% of them are having impaired glucose tolerance, so at a very young age. And we also looked at their quality of life. Now, obesity is associated with psychosocial adverse effects, and we found that children who were obese and overweight had impaired quality of life. And I'm proud to say, sir, that some of this work was done by our very own undergraduates, and it was published in a high impact journal. So it just shows that undergraduates are a very useful and valuable part of our research community. So I also did another audit looking at what was happening in these children over 2 years. And again, you can see in 116 children, they had a body fat percentage of 42% when we started. And 2 years down the line, we were preventing a further increase, but we were not seeing any reversibility. And I also tried whether group therapy would work. And that's what you can see on the lower picture, focal group discussions lasting more than an hour, trying to motivate these children, talking to them. But we found only a short-term advantage, and it was not sustained with longer term. So ladies and gentlemen, we were having a real problem in Sri Lanka. And so I thought whether some of the knowledge I gained from New Zealand could be applicable to Sri Lanka, and whether we could look a little bit deeper into the problem in Sri Lanka to find a way towards a solution. So this is one of the papers that really got me thinking. This was the Sri Lanka Demographic and Health Survey in 2006-07. And if you look at this, it shows the body mass index of women of reproductive age of that year according to the sector. And the first, so you can see that in light brown, these are women who are overweight or obese. This is based on the WHO cutoff. So actual rates are even higher for South Asians, but we were seeing that more than half or nearly half of urban women of reproductive age in Sri Lanka were overnourished, obese or overweight, and 1/3 of rural women as well. And on the other hand, when you look at the blue sector, we had 33 or 1/3 of women in the estate sector who were undernourished. So ladies and gentlemen, we were having a double burden of malnutrition in Sri Lanka, which was probably contributing to a lot to fetal programming on both ends of the birth weight spectrum. So how do we go from here? So I think it's very important for us to understand this concept and recognize there are various groups of people or women that we need to target. So we still have women who are undernourished, who will give rise to babies who are small for gestational age, who, if we do not educate the field staff and the parents, will have, if they have excessive catch-up growth during pregnancy, during childhood, will have central obesity. The Barker hypothesis, they will have central obesity and diabetes by the time they reach their reproductive age. So ladies and gentlemen, we are seeing this cohort a lot, ladies with gestational diabetes, and they will give rise to large babies who we are again also seeing a huge rise in childhood obesity at a younger age in Sri Lanka. And these children are also going to be obese as adults from a different phenotype, and also have obese children. So we are having these 2 cycles operating, and this was something we just did a cross-analysis of the obesity complications of the children I spoke about earlier, and we found that even at a similar BMI, the girls were having actually worse metabolic outcomes. So the girls had higher insulin resistance compared to the boys. So this was not arguing well for Sri Lankan population. So what was the way towards the solution? How can we break the diabetes cycle in Sri Lanka? And this is the approach that the WHO is now advocating. We need to have a life cycle approach. We need to target all these sectors. So improve maternal undernutrition, encourage our population and our field workers not to overfeed the children who are small, which is happening at a massive rate. They should not have catch-up growth. If they do, they will have gestational diabetes. I think we are now having universal screening for gestational diabetes in pregnancy because we are such high risk. We also need to realize that the babies born to these mothers of gestational diabetes and obesity are going to be obese as kids, and they are going to be obese as adults. So we need, I think, multi-sectorial an approach to curb this problem. And I think it's very important for us to realize that we need to encourage a healthy BMI, especially among the very young children, as well as our adolescent girls. And so I was fortunate enough to have the opportunity to work with what we affectionately call the Chandivandi project, which was a 3-year multi-state, multi-collaborator project funded by the World Diabetes Federation, where I was leading the Stool Health project. And we wanted to create a program to educate, encourage, and empower young primary school children to be more mindful of what they were eating, encourage healthy lifestyle changes, and prevent obesity and type 2 diabetes in themselves and their family. So we created 2 educational tools. One was a storybook, which was to educate and encourage healthy lifestyle and eating, which was based mainly on my focal group discussions with the obese children, really going down to what was happening at school level. And we also created this food diary using stickers, which helped them to monitor their diet. And we had some stickers to show them whether it was healthy or not. And we were very happy to we found an immediate as well as a sustained improvement in healthy eating habits. And furthermore, the obese children who had improved their eating habits had a improvement in their BMI as well. And so this work was published last week. And the parental feedback and the teacher feedback was also very positive. So we were very happy, and the Ministry of Education worked with us, and we were all set to do a special project in the Nutrition Month of 2020 to reach 750,000 young school children across all schools in Sri Lanka. And we came up with a low-cost option to make it more cost-effective. We also trained all the in-school advisors around the country to deliver this program, but unfortunately, one pandemic was overcome by another. So COVID-19 came and the work could not be continued. So ladies and gentlemen, these are the 2 key messages that I hope to deliver today. One is that unhealthy lifestyle with fetal programming is playing a major role in the rapid rise of obesity and diabetes among the younger generations of Sri Lankans. And educating and empowering young children and adolescents to achieve a healthy BMI and healthier lifestyle is urgent. So, ladies and gentlemen, I hope you agree with me that an ounce of prevention is probably worth a pound of cure. And I wish to acknowledge so many people, but firstly, let me thank my dear supervisor and clinical supervisor, as well as my PhD supervisor, Professor Paul Hoffman. Paul, I hope you're listening in today. He's in Asia Pacific region trying to help many other countries. And my secondary supervisor, Professor Wayne Cutfield, and all my team and staff and friends at the Liggins Institute for keeping me for 3 years and enlightening me and sustaining me. And I would like to thank all my teachers, mentors, colleagues, and friends from the Faculty of Medicine, especially those from the Department of Pediatrics who covered up for me the 3 years I was away from the department, and also all my colleagues at the Lady Ridgeway Hospital for Children, and very especially my little patients and their families who continue to inspire me to try and solve this problem. And I also want to thank this group of young ladies who worked energetically and very enthusiastically as part of the school health component of the Sri Lanka Diabetes and Cardiovascular Initiative, and the multiple stakeholders, the school authorities, school children who actively participated in the Chandibandi project, Ms. Renuka Piris from the Ministry of Education who helped us with everything. And I would also like to thank the NCD Alliance Lanka, who has also encouraged me to look at this problem from a community perspective. And finally, I must acknowledge my parents who are here with me today, and my mother-in-law and father-in-law who unfortunately could not be here today, for all their help and support and guidance in helping me look after my young kids while embarking on all this work over the last 10 years. And my children, these were the passport photographs when we went to New Zealand. My son was 5 years, my daughter was 9 months. So they've dedicated, I mean, I've spent a lot of time doing this work. And so now they are nearly adolescents. And I'm very grateful for their patient understanding. And finally, Sanjeeva, you've been a pillar of strength. Sanjeeva is the person who encouraged me to do this PhD. And today I stand here thankful that I took up the challenge. So ladies and gentlemen, I hope you enjoyed this trip around the globe and back. And I wish you from New Zealand, kia ora and aivowan, may you live long. And I hope that we will all work together to beat the diabetes pandemic in Sri Lanka. Thank you very much.